Some of you have said bronchiectasis. Some of you had I'm assuming you mean primary bronchiectasis. Neda has said air bronchogram in concept of consolidation, and that's absolutely right. This is consolidation. So this is the point I was trying to make. There is sometimes you can see dilated bronchi in consolidation as well, and that presence of air bronchogram can immediately make you think, is this bronchus dilated or is this ILD? This appearance is a bit more prominent that you would see in normal consolidation. So when consolidation heals, or when depending on which stage you're imaging the patient at, the air bronchograms within a consolidation can also look irregular. So if you had that scan and you saw those bronchi, you can't diagnose that as permanent. You can't diagnose that patient with ILD, even if you were uncomfortable with the degree of or the diameter of the airways. You have to recommend follow-up, because in most cases that will resolve when that patient improves. When that consolidation resolves, you would see that the bronchi will go back to its normal. So within active infection, within active inflammation, you can see dilated bronchi, and you can't label that as a permanent change. You can't label that as ILD or primary bronchiectasis within active consolidation, was the point I was trying to make. Other abnormalities quite commonly seen in ILD are cystic changes, and this can be very hard to differentiate even for the most experienced radiologists. So don't be alarmed when you find yourself staring at a cyst and not trying to figure out whether this is a cyst or whether this is emphysema. It can be hard, and it can be even harder because of the fact that the patients that have cystic lung disease also happen to be the same patients that can have emphysema as well. So a patient can have both of them at the same time, and that makes it harder to diagnose. When it's a cyst that is thick-walled, like number 2, it's much easier to diagnose that. It's much easier to call that. But obviously, when you have thin wall cyst and thin to the point that you can't even see the wall or barely perceive the wall, then it gets slightly more tricky. If you look at number 4, you can see that this is a cyst because there's nothing else around it, immediately around it, that looks like that. You can see the wall. You can see it's a thin wall, but you can see the wall. When you look at number 1, and if the question is, does the patient have cystic lung disease, you have to look a bit more closely, and you have to look for the signs that can help you differentiate between emphysema and cystic lung disease. So in cystic lung disease, you are saying that the cysts are within the lung parenchyma. In emphysema, what you are saying that the cyst, what looks like a cyst or a space, is actually destruction of the airspace. So emphysematous spaces do not have walls. What they do have is remnants of structures that used to be normal lungs stranding through them. So when you look, it's called a central dot sign. So the vessel that once upon a time used to supply that part of lung is still alive. You can still see a strand of it in the middle, and the surrounding airspace has since been completely destroyed. So in emphysema, if you look for the central dot sign, it will help you differentiate. So presence of a central strand, a central dot in a cystic space implies that this is actually what used to be normal lung once. So this is not actually a cyst, it's just end-stage disease or end-stage appearance of something. And in most cases, that will be emphysema. And in the context of ILD, that will be honeycombing, but we'll come to that in a bit. So moving on to more specific disorders, the first one we'll look at is sarcoidosis. Sarcoidosis is a very interesting disorder in the sense that not only is it multi-system, multi-organ, it has a very, very wide range of presentation in terms of what it can look like on imaging and also what the patient can look like. So sometimes it's an incidental finding. Sometimes the patients can be really, really unwell. And the age doesn't really help as well. They can be early 30s to late 70s. So it's a very difficult but interesting disorder to look at. And it also happens to be a big exam favorite for a lot of examiners. So it's really important to be clear on sarcoidosis because sometimes it can also mimic or raise the suspicion of underlying malignancy. So it becomes really important to be very clear on not only the stages, but also what imaging can look like and what you need to do. In terms of the stage of diseases, I'm sure most of you know these stages already, but just to put that into context, is the probability of complete resolution reduces a lot depending on which stage of sarcoidosis you are in. When you are in the fourth stage or in the stage of complete fibrosis or early established fibrosis in sarcoidosis, there will never be a point that your lung will return to normal. If your fibrosis is stable, you can live a normal life. If your fibrosis goes on to be progressive, you can end up with right heart failure or pulmonary hypertension, and in the end, the only resort you will have is to be put on a transplant list. Stage 1, stage 2, stage 3, still potentially reversible, completely reversible, but the chances of completely resolving reduce as you go up in stage. It is a multi-system disorder. I'm not going to claim to be a neuroradiologist and tell you all about neurosarcoidosis, but sometimes the patients can present with symptoms very far away from the chest or have nothing to do with the chest. And if the differential happens to mention sarcoidosis, they can end up having HRCTs to exclude sarcoidosis. The patients can be completely asymptomatic from the lung point of view, even if there is very clear abnormality on the CT. So sometimes the CTs are to look for sarcoidosis in an asymptomatic patient, or it can be an incidental diagnosis you make for non-specific symptoms. In terms of musculoskeletal changes, they can be appendicular silicon, they can be in the skull, they can be in the hands, the feet. Like I said, I'm not going to go into detail, but this is just put into perspective that the patients can end up with an HRCT from a multitude referral sources. They can be orthopedic referral, a neurosurgeon referral, or a respiratory physician referral. If you had that skull X-ray in front of you, I don't think any of us would go with sarcoidosis being our first diagnosis. Most of us, and rightfully so, would think of diffuse or lytic metastases of the skull. So it can present in very alarming ways, in very progressive, destructive skeletal changes, but it can be multi-organ. And if the skeletal changes are very advanced, if the neuro changes are very advanced, it makes no impact, or it doesn't tell you in any way whether the lung is involved or not. So the severity of extrapulmonary sarcoidosis doesn't correlate necessarily with your thoracic implications or thoracic changes. And this is a gallium scan. I will open up the chat again and ask if anybody knows what this appearance in sarcoidosis is called. Okay, 30 seconds starting now. Yeah, most of you are absolutely right. This is the panda sign that is seen on the gallium scan. How many of us actually do gallium scan in our every day-to-day practice in sarcoidosis? I don't think many of us do it. Again, this is a historical piece of information that is not really practiced very widely, at least in the UK anymore. We largely look at PET and MR and CT as the main imaging modalities we use for sarcoidosis. The panda sign is bilateral involvement of the parotid and the lacrimal glands in sarcoidosis. When it's superimposed on the normal uptake in the nasopharyngeal muscles, that can look like a panda's face. So that was what was described as the panda sign in sarcoidosis. This is called the 1-2-3 sign, or the typical chest X-ray that you will see. This will typically be in a young patient, early 30s, fit young man presenting with non-specific symptoms of lethargy, malaise, maybe low-grade fever. A very smart respiratory physician has done a serum ACE level, and that is increased. And that is what a chest X-ray looks like. So this shows you bilateral hilar enlargement, lobulated looking, and you can very clearly see that there's something in the right paratracheal space. So that's called 1-2-3, 1 being the paratracheal and 2-3 being the 2 hilar. Garland is a wreath or a string that is described to used to describe that appearance. His appearance is also called pawnbroker symbol or pawnbroker sign. Um, these two signs are just used to describe the very typical appearance of bilateral hilar and right paratracheal lymphadenopathy in a very uh, not so long ago. The same appearance you could see in TB as well, but this appearance of these signs are reserved more for sarcoidosis. The pawnbroker sign is just it's an interesting sign. It's just the pawnbroker symbol is actually the symbol of the Medici family. So I don't know if many of you are very interested in history or not, but Medici family is the family of bankers that are famous for the art collections in Florence, Italy. But the Medici family symbol is actually three balls that the legend was that there was a very famous giant that was slayed by a Medici man using three rocks that he threw at him. So that three gold balls hanging on a lamp are actually symbols of the Medici family. So pawnbroker sign is a type of banking that the Medici family came up with in Florence. So that's why it's called that sign. So the pawnbroker is actually the Medici family, and the symbol is the three gold rounded opacities. Uh, Again, reiterating the stages of sarcoidosis, hilar and mediastinal lymph node enlargement is easier to diagnose, is usually the initial presentation in younger people. And the question, and rightfully so, the differential that needs excluding is lymphoma. Lymphoma is seen in the same age group. The lymph nodes, if uncalcified, can be more confusing with lymphoma. If you see specks of calcification, it becomes more easy. You don't really see calcification in the acute presentation. It takes time to develop. The enlargement comes first, and the healing stage and the chronic stage sees that lymph node calcification. If you have calcified lymph nodes and they're slightly enlarged, you're more reassured that it's a benign pathology. But when you have non-calcified lymph nodes that are large and rounded with the loss of the fatty hilum, you really have to sample them. Even if you're radiologically very sure that this is sarcoidosis, the procedure or the norm is that the respiratory physician will still sample these nodes endobronchially and will have a tissue diagnosis of sarcoidosis. Sometimes we see parenchymal disease with the nodal disease, and that's obviously stage 2. Stage 3 is when you see parenchymal disease only. And like I said before, the chances of spontaneous resolution decrease as you go up in stage. And the fourth stage of when they present with pulmonary fibrosis is obviously completely, they will never be a point that they will resolve completely or go back to how the lung was before sarcoidosis. It's not uncommon to see people with stage 4 sarcoidosis having no memory or no history of ever having stage 1, 2, or 3 sarcoidosis. So they could have had sarcoidosis 10 years ago, 20 years ago, a year ago, and not have realized it symptomatically. And like I said, the degree of acute change or the changes in the stages 1, 2, and 3 do determine the chances of you getting fibrosis, but it's not a linear correlation. So it's not like if somebody presented with very severe disease, very large lymph nodes in stage 1, we can predict that they will end up with stage 4. It doesn't work that way. The parenchymal extent of disease is slightly more correlatable, but some people respond very beautifully, some resolve completely, and some just go on to have this smoldering disease that in a few years can become very aggressive suddenly. So there's no way of actually predicting the prognosis of it based on a scan. So these patients don't go under routine surveillance of scans. The scans or the follow-up scans are more dictated by the clinical scenario. So the respiratory physician will see the patient. If they look asymptomatic, if they're doing well, they're not going to be getting scanned again and again. If they do deteriorate, if their lung function deteriorates, they get repeat imaging. And whenever they get repeat imaging, the question to you or the chest radiologist will always be, is there active disease? And what they mean by active disease is there nodularity? You can have calcified lymph nodes or you can have fibrosis and not have active disease. Fibrosis will always be fibrosis, even if it's stable and will stay exactly the same severity for the next 20 years. It's not classified as active disease. If you have lymph node enlargement that is calcified and is stable, it's not called as active disease. It's the parenchymal disease, the changes in the lung parenchyma that determine whether that is active disease or not. And the abnormality you're looking for is nodularity. Nodularity of the fissures, nodularity of the bronchovascular bundles. And when the nodularity is so advanced that there are a lot of small nodules sitting next to each other, they can also coalesce together in what is traditionally called the galaxy sign. So it can look like there's a collection of nodules there, and it can also look like one large nodule. If somebody asks you, are you absolutely sure this is not an incidental cancer in the middle of all that sarcoid change? The answer is no, there's no way of knowing. Are you going to biopsy that? No, you're not. You're just going to go on and follow up the patient. These nodules, these coalesced nodules, can sometimes be very prominent. They can be bilateral and they can be quite worrying looking. So then the differential for bilateral metastatic disease comes into play. And sometimes then when you don't see the micronodularity around it, and when you see these bilateral nodules, sizable nodules, it is sometimes worth getting a diagnosis just for reassurance purposes. This is just a magnified view of the nodularity. So nodularity of the bronchovascular bundles, perilymphatic, peribronchovascular, and the fissural nodularity. Whenever you have a scan that you are thinking down the lines of sarcoidosis, your eye should immediately be drawn to the fissures. If you scroll up and down and the fissures are nodular, you're pretty sure by that point that you are going down the right route and you are going to call that patient as parenchymal sarcoidosis. When it's stage 4, then the diagnosis isn't that easy to make, because you have a lot of other diseases that can give you upper to mid zone fibrosis, and sarcoidosis happens to be one of them. On a chest x-ray especially, the appearances are very non-specific. So they can be asymmetrical, they can be symmetrical more common. Upper to mid zone fibrotic changes, and then the differential has sarcoidosis in it. I will open up the chat and I will ask you guys to tell me what else that can be. So differential diagnosis for upper to mid zone fibrosis. 30 seconds. Okay, perfect. Thank you. And it's great to see all of you engaging with the chat, and all of you are giving very good differentials. Somebody has said advanced hypersensitivity pneumonitis, and I would really encourage you guys not to use terms like advanced. It's either acute or chronic or subacute. We'll come to HP in a bit, and hopefully by the end of today's session, you will know what to call acute and chronic in terms of HP at least. Yes, the differential is absolutely right. Upper to mid-zone fibrosis, particularly apical fibrosis, you can have TB, radiation, ankylosing spondylitis, silicosis, pneumoconiosis. And the thing that makes it slightly more confusing, especially with chest X-rays, is that not only TB, but RA, silicosis, pneumoconiosis, all of these can have calcification. So they can have lymph node enlargement of the same distribution, they can have lymph node calcification, they can have a bit of parenchymal calcification, and the differential doesn't really change. So if I now asked you what is the differential of calcified lymph nodes with calcified lung nodules and upper to mid zone fibrosis, your differential would almost be the same. So it doesn't really help. Once you have upper to mid zone fibrosis, you can't really narrow it down any further than the differential you already have, especially based on X-ray. There is an appearance on CT that is quite specific to sarcoidosis. It's unfortunately not that commonly seen, but when it is seen, it becomes very easy. And those of you who have seen it once will always remember what it looks like. And the way to remember it is when you have a CT chest and it's a supine scan, what you want to look at is when it's sarcoidosis, it's upper to mid zones, and it looks like somebody has taken the bronchi and they have pulled them back. So, like if somebody was standing in front of you and facing the other way, and you took their arms and you pulled them back, that's how it looks like when you look at the lung. It looks like there's somebody pulling it back and laterally. So the bronchi are going to curve back and curve laterally. And all the architectural distortion, all the volume loss happens in that direction. And it's a very specific appearance. And once you see it, it's very, almost nothing else causes it. Especially if it's symmetrical. So if it's TB, it's going to be more irregular. When it's sarcoidosis, it's going to be more specific or more uniform. So that's what you can look for in terms of CT. So it becomes slightly uh, more helpful. Can it be PMF? Yes. Sarcoidosis does not cause PMF. No. So PMF is progressive massive fibrosis. For those of you who don't know, this is commonly seen in occupational lung disease. So the posterior pulling is not specific to PMF. PMF can happen anywhere. So wherever that massive fibrosis or mass-like fibrosis is, it's going to pull towards it. So that PMF can also be in the lower lobe. It can be all over. It's predominantly upper to mid zone, but it's not specific to posterior architectural distortion. Again, CT upper to mid zone fibrosis. This is what end stage or fourth stage of sarcoidosis looks like. What happens in fibrosis is with the part of the lung that loses volume or collapses or becomes fibrosed, the lung around it is inevitably pulled to expand. So you have compensatory hyperinflation of the lung around it. For example, here you can see this part of the lung almost looks like it's turning into a pull-up because the fibrosed part of the lung is pulling it. What happens in that scenario is that that will ultimately turn into a cavity. You can have a cavity inside a dead part of the lung or a fibrosed part of the lung, and that cavity is essentially a breeding ground for opportunistic infection. So that's what happened in this CT, and that space has actually grown in aspergilloma. So it's a very common complication in end-stage lung disease or fibrosis is when you have cavities, they do fill up with aspergilloma. This is a more typical appearance of the calcified lymph nodes and the volume loss. Again, a more advanced, more typical appearance, but if you can appreciate, it has gone down into the lower lobes as well. So the more severe the disease gets, the more it comes out of its comfort zone and starts moving to the lower and mid zones as well. It is a multi-system disease, so at some point or the other, they may present with symptoms from another body organ, or abdominal pain, or cardiac arrhythmias, or general ill health. And if somebody does progress a lot, or they're quite symptomatic, they can have PET scans to look for uptake and extent of disease. In terms of cardiac abnormality, what was previously done with nuclear imaging is now done with cardiac MR. So I don't expect you to be experts in cardiac MR, but in terms of exam purposes, just something to remember by when you have infiltrative cardiomyopathy, or you have an abnormality in the heart muscle that has infiltrated the muscle with abnormal cells rather than ischemia, you have mid-wall or epicardial inflammation. So that part of the lung shows as late gadolinium enhancement on late GAD images in cardiac MR. So mid-wall enhancement is very typical for infiltrative cardiomyopathies, and sarcoidosis is one of them.